Good morning, everybody. My name is Ruparam, and I am a radiologist at the University of Arkansas for Medical Sciences. And it's my absolute pleasure to introduce to you Dr. Ghada Issa. She is the Division Director of Ultrasound and Assistant Professor at Brown University. Ghada has previously trained in radiology at the University of Maryland Medical Center. She used to be the chief resident in her final year. She's also done an abdominal imaging and interventional fellowship at the Brigham and Women's Hospital. And she will talk to us about imaging of renal neoplasms and highlight to us the importance of doing biopsies on renal masses. Over to you, Ghada.
Thank you so much for the introduction. Good morning, everyone, or good evening, wherever you are in the world. I'm so glad to be joining you today for my talk about solid renal neoplasms. So I'm gonna get started. I have no disclosures. So this is the outline of our talk today. We're gonna go over the classification of renal tumor with emphasis on the 2016 WHO classification. We're going to review the imaging of renal neoplasm, especially the solid neoplasm. Cystic neoplasm are not going to be included in this talk. We're going to go over the management, especially when it comes to the recommendation of the American Urological Association, and then the role of percutaneous biopsy. So interestingly, in 1952, renal cell carcinoma were divided into basically two categories, clear cell or granular cell. And moving forward to 2016, the WHO classification has more than 50 different entities of renal tumor. It is based on a combination of morphological, cytological, cytoplasmic, molecular, and genetic features. So the classification is a little bit overwhelming, but the take-home messages mainly is that RCC remains the most common renal tumor in adults, and they are divided into different histological subtypes. The most common, as everyone would know, is clear cell type, which encompasses 70 to 90% of RCC, and then papillary is 10 to 15%, and chromophobe 3 to 5%. But you do see that there's also more than 10 different subtypes in this image here. The main changes were that multilocular cystic RCC name has been changed because there has been no reported metastasis or recurrence, and it is now known as multilocular cystic renal neoplasm of low malignant potential. And if you notice, after each code for the classification, you see a number that ranges from 0 to 3, and that's basically the behavior, the biological behavior. So 0 is benign, and 3 is malignant, and everything in between is borderline or carcinoma in situ. So you can see that the multilocular cystic renal neoplasm of low malignant potential is 1. And then other changes were changing the definition of renal papillary adenoma, which is basically an encapsulated papillary RCC grade 1 and 2 that is less than 1.5 centimeters. Previously, it was less than 0.5 centimeters. And this makes a huge difference in renal donor and renal transplant, because it is, no longer an exclusion to renal transplant if a renal papillary adenoma is less than 1.5 centimeters. There has been also newly recognized epithelial tumor like the hereditary leiomyomatosis and RCC-associated RCC, the succinate dehydrogenase deficient RCC, tubulocystic acquired cystic disease associated RCC, and the clear cell papillary RCC. So moving on to imaging, with all these subtypes, we can imagine that renal tumors are very heterogeneous, and renal cell carcinoma also has a lot of morphological heterogeneity. It is with the use of imaging, we have been finding more and more incidental solid renal masses. So imaging is used, for other conditions, and then every day, I don't exaggerate when we say that every day we find an indeterminate renal lesion on imaging. And actually, more than 50% of RCC are detected incidentally. So, imaging is useful, number one, to detect those incidental lesions, and then to try to characterize them. However, the differentiation between benign and malignant solid tumor remains a particular challenge. We will review a few imaging characteristics, and then imaging for sure is used for staging. So using different imaging modalities, we're going to start by ultrasound, which is very dear to my heart. Unfortunately, ultrasound has a limited role, though, in the evaluation and further characterization of renal neoplasms. The echogenicity does not differentiate different subtypes. Most RCC less than 3 centimeters are hyperechoic, but so are other renal neoplasms, especially angiomyolipomas. Color Doppler can prove that a mass is solid but cannot predict malignancy. And then color Doppler sometimes is not sensitive enough for a tumor that are hypovascular like papillary RCC. Here comes the role of contrast enhanced ultrasound, which is more sensitive in detecting hypovascular solid lesions. There is a lot of data out there proving that the characterization of renal tumor as benign or malignant can be done with contrast enhanced ultrasound with great negative predictive value and positive predictive values, as you see. However, in those studies, most lesions were cystic. So there's still a limited role, even for contrast enhanced ultrasound, to characterize solid renal tumor, but it can definitely prove that a mass is solid. So I have an example here of a lesion that was incidentally noted on a non-contrast CT of the abdomen and pelvis. Measuring the ROI, it measured 25 house field unit, which according to the new Bosniak classification, you can call it a simple cyst. However, we know that there are limitations because many of the renal tumors, especially papillary, can have this low than threshold house field unit. And even with use of contrast enhanced CT or MRI, sometimes they show below contrast enhancement threshold. So this patient had end-stage renal disease and they had allergy to intravenous contrast, and therefore contrast enhanced ultrasound was a good next step for them. This is a grayscale ultrasound showing this mass that did not show any color flow, vascular flow on color Doppler. And then we went and we gave our contrast agent. We used Lumasone, and then you can see that it is enhancing. It is still hypo enhancing compared to the renal parenchyma, but it was enhancing, and this ended up being a papillary RCC. Moving from ultrasound to CT, renal mass protocol is widely used, especially as a next step for characterizing an incidental renal lesion. So renal mass protocol, this is the protocol based on the Society of Abdominal Radiology. It needs to have at least 2 series, a pre-contrast and a nephrographic phase, which is acquired at 100 to 120-second delay after contrast administration. And then optional series or sequences are the corticomedullary phase, which is at 40 to 70-second delayed, and this is used mostly to subtype RCCs. And then expiratory phase is also optional, 7 to 10 minutes, and this is mostly helpful to differentiate urothelial cancer from RCC, as well as to differentiate pedipelvic cysts from hydronephrosis and calyceal diverticula. And then imaging with CT is definitely helpful to find macroscopic fat in renal neoplasms. However, the caveat is that up to 5% of angiomyolipoma, which is our most common renal neoplasm containing microscopic fat, can be fat poor. And then, as I previously mentioned, that the enhancement criteria is usually a 20 household unit difference between the pre and post contrast. However, there's caveats that some hypovascular RCCs show no enhancement or less than threshold enhancement, and this number is up to 25%. And then the other limitation is the pseudo enhancement, where you would have a more than 20 household unit, but it would be because the collecting system had excretion and it's causing pseudo enhancement or associated artifacts surrounding the kidney. Other emerging modalities in CT to characterize renal neoplasms is dual energy CT and then CT perfusion. I'm just gonna briefly show this example about post ablation zone where the arrow is pointing. It was hyperdense on the non-contrast images, and then after administration of contrast, the difference was about 17 household unit, which is indeterminate. But you can see that after this is basically an iodine map, dual energy CT. You can see that there is no iodine uptake, meaning that there's no residual tumor in this ablation zone. Now, MRI, these protocols are also from the SAR. For the sequences, recommended sequences are a T2 and a T1 weighted images. The T1 should be fat sat, and then definitely an in and out of phase T1 weighted gradient echo sequence, and then contrast administration with 3D dynamic sequences in at 30, 90 to 100, and 180 to 210 seconds. Optional additional sequences are the coronal and diffusion weighted sequences. Intravenous contrast, recommended use is the extracellular gadolinium-based contrast material. There are specifications about the volume and the injection rate. It is the first line modality recommended for heterogeneous indeterminate masses on CT, because you can imagine that CT might miss subtle enhancement within septations if it's a cystic or mixed cystic and solid lesion or small nodularities. As well if there has been a hemorrhage or necrosis. The T2 signal on MRI helps narrow down the differential, meaning that we have a handful lesions that will look T2 hypointense on MRI, which we're gonna go over them as well. And then it is also helpful to evaluate for microscopic fat as opposed to macroscopic fat on CT. And then lesions that has microscopic fat are mainly clear cell RCC versus fat poor angiomyolipoma. And of course, the enhancement pattern can be very helpful on MRI. Now we're just gonna go over a few examples. So we're gonna start with the different subtypes of renal cell carcinoma. The most common, as we mentioned, is clear cell. Clear cell RCC can be either expansive or infiltrative. It is heterogeneous and hypervascular. It is typically T2 hyperintense, but it might have hemorrhage or necrosis, which can cause T2 heterogeneity. And then, as also mentioned, it may contain microscopic fat or macroscopic fat. However, especially when it has macroscopic fat, it usually is with calcifications, and that's a very important feature to differentiate it from lipid-rich angiomyolipoma. So this is an example of an RCC with necrosis, and this lesion was subsequently biopsied. Many of the examples that I'm going to show in this talk today are going to be biopsy proven. Now moving on to a papillary RCC, the second most common subtype. Papillary RCCs are usually the opposite, homogeneous and hypovascular. As mentioned, enhancement may be below the threshold on CT. It is typically T2 hypointense, and then it's common to have bilateral and multiple tumors. Chromophobe RCC is usually a well-circumscribed tumor. There are overlapping features, however, with oncocytoma, which we're going to review in a few slides, including the typical central scar and even the histology. It has a variable signal on T2. However, it is usually intermediate signal to low, not hyper intense. And then it has also a homogeneous enhancement, although less than clear cell carcinoma, but more than papillary subtype. So it resides between these two types. This is an example on ultrasound of a chromophobe biopsy proven RCC vascular on color flow interrogation. It is mostly T2 hypointense with scattered area of T2 hyperintensity, and it showed homogeneous enhancement after contrast administration. All right. Just checking the chat to make sure. All right, now we're gonna show an example about one of the newly recognized subtypes of RCC. So that's a clear cell and papillary RCC that arise from a transplant kidney. It's usually a well-circumscribed mass with a fibrous capsule. It might have a cystic component, and then there's overlapping features of both clear cell and papillary subtypes, signal and enhancement-wise, on MRI as well as on CT. So this patient had an old transplant in the left lower abdomen, as you can appreciate, and has a newer one and the right. And then on T2, this is a T2 weighted sequence. You see that the mass has mixed T2 bright and low signal. And then on contrast enhanced sequences, it showed homogeneous enhancement. This was as well a biopsy proven clear cell and papillary subtype RCC. Now, one more example of RCC is a mucinous tubular and spindle cell, which is usually well circumscribed. It shows slow homogeneous enhancement with plateau dynamic. It is T2 hyper intense, although this depends on the mucin content, which it has, and then it typically shows a low ADC. This is another biopsy proven mass from our institution that was actually incidentally found, and you can see it hypo enhancing on contrast enhanced CT. It had a mildly bright T2 signal, iso intense to hyper intense, and then it did show a really low level enhancement with diffuse septations. All right, now moving on to another renal malignancy, which we should always keep in mind is renal lymphoma. Renal lymphoma may present in a variable way. It can be either a single renal mass, multiple masses, it can cause diffuse infiltration, or it can present as a perivenous rind. It can be hypoechoic on ultrasound and hypoechoic with even a posterior acoustic enhancement. So that's always a caveat that it can mimic cystic lesions. It is hypovascular. And then on MRI, it is usually T2 iso intense to slightly hypo-intense. And then on FDG, it is FDG avid on PET-CT, although we do say that FDG PET-CT use is limited for renal neoplasm, but with lymphoma, despite the caveat of having excreted FDG, you can still appreciate the FDG avidity in this example. So this is a correlation between the ultrasound, where we see there is very minimal, if any, vascular flow on color Doppler and the fused FDG PET-CT images. This is another example of a biopsy-proven renal lymphoma that I'm adding the biopsy images here. We had to actually go through the liver to get to this exophytic mass that was also hypo-dense on CT and low-level enhancement, and it was proven B-cell lymphoma with high-grade features. Now, moving on to angiomyolipoma, which is one of the common incidentally found renal lesions. It has three subtypes: fat rich, fat poor, and fat invisible. Fat rich is not a diagnostic dilemma. It is fat density on non-contrast, non-enhanced CT, and usually less than -10. And then no calcifications or necrosis, because as we just mentioned, the RCC occasionally can have macroscopic fat, but in these instances, it be associated with calcifications. Then fat poor AML, which is actually 5% of all angiomyolipomas. It is usually a non-fat density on CT more than -10, and then it has variable degrees of contrast enhancement. Sorry, this said 10, but it should be -10. And then the third category is the fat invisible, which is more of a diagnostic challenge because it's very hard to differentiate from RCC. Fat invisible AML is usually hyperdense on non-enhanced CT, and then it also shows homogeneous enhancement. Now, MRI can add a few more helpful tricks to differentiate angiomyolipoma, the different subtype, and differentiate them from RCC. The T2 weighted images usually show a T2 hypointense lesion. However, this is helpful to narrow it down, but not very helpful because many especially non-clear cell subtypes of RCC like papillary would be T2 hypointense, as well as other benign tumors like oncocytoma. There has been research out there about using chemical shift to differentiate different angiomyolipomas using the tumor to spleen ratio and the signal intensity index. So that's another helpful features, although it's not widely available. Not everyone has MRs available and can perform all these advanced imaging. And then DWI and ADC, it is reported that fat invisible AML is usually restrict diffusion, and then more than fat poor AML, and definitely more than clear cell RCC. But the other caveat is that non-clear cell RCCs can also restrict diffusion. So you can appreciate how heterogeneous this group of solid renal neoplasm are, and we have a lot of overlapping features. These are a few examples of AMLs. We're seeing here a lipid-rich AML where you can appreciate fat density on non-contrast CT. Second row here is a fat-pooled AML, which was biopsy proven and T2 hypointense. And this is another example on contrast-enhanced CT where you can appreciate mildly heterogeneous enhancement. And then the last example is of a fat invisible AML, T2 hypointense, like many other solid renal neoplasms, slightly hyperdense on non-contrast CT, and a homogeneous enhancement after contrast. Oncocytoma, as we mentioned, is one of the very common benign tumor that are actually found in nephrectomy specimen that we're going to mention in a little bit. This is a nice example of two tumors in the left kidney. The larger one ended up being an oncocytoma, and then you see there is a smaller tumor here that ended up being papillary RCC, both of which were biopsied. You can appreciate the similarities in imaging features both on CT and MRI. They both show T2 hypointensity, and then after contrast enhancement, oncocytoma maybe has more enhancement than papillary RCC, but they are both hypoenhancing compared to the background venal parenchyma. Oncocytomas usually alveolar circumscribed masses. They may have a central scar. They have variable enhancement pattern, depends on the cellular contact. They may coexist with RCC, as we see in this example, but it is very hard to differentiate them from RCC with oncocytic element, even on pathology. So that's basically a diagnostic challenge for radiologists and pathologists as well. Oncocytomas can be multiple. In these cases, they would be either sporadic or associated with Birt-Hogg-Dubé syndrome. And then we have an entity called renal oncocytosis, which is an example of it here, where we have numerous oncocytic neoplasms tumors that replace the renal parenchyma, and they can range from oncocytomas to chromophobe RCCs to any RCC with oncocytic element. So you see multiple masses. The featured here are one mass on the right side and two masses on the left side, and this is the ultrasound correlate. Now, another unknown entity, but it's not uncommon, is metanephric adenoma. It is usually a well-circumscribed mass. It is high so dense to hyperdense on non-conscious CT. It's benign. T2 hyperintense on MRI, although it might have hemorrhage or necrosis. And then one important feature that's not characteristic, but it is supportive of the diagnosis, is that metanephric adenomas restrict diffusion in small series. Almost all metanephric adenomas restrict diffusion. As we can see in this example, we see a mass exophytic at the right kidney, hypo enhancing compared to the renal parenchyma, and this is the DWI and corresponding ADC. This lesion actually had central necrosis, but you can see that the periphery is restricting. Now, this is an example that I like to show about a 64-year-old male who, this is the presenting study where he had a renal mass that was not biopsied. He went for partial nephrectomy, and then this was an oncocytoma. And then many years later, he presented, you can see the nephrectomy scar in his left kidney here. He presented with another mass, and then at that point, his kidney function was deteriorating, so they elected to take him for biopsy and ablation. And this is an image from the procedural study, and the biopsy revealed another oncocytoma. Now, after seeing all these examples and the overlapping features, I'm going to review briefly the management recommendations that are mostly from the American Urological Society. So in these recommendations, patients with a solid renal mass, the recommendation is for physician to obtain high quality multi-phase cross-sectional abdominal imaging. Great, we all agree. In patients with suspected renal malignancy, metastatic evaluation should include chest imaging. And in patients with solid renal mass, physicians should assign the CKD stage based on the GFR and the degree of proteinuria. Renal mass biopsy, according to the AUA, should be considered when a mass is suspected to be hematologic, metastatic, inflammatory, or infectious in origin. Renal mass biopsy is not required per these recommendations for any young or healthy patient who otherwise is unwilling to accept the uncertainties associated with renal mass biopsy. And then it's not recommended for an old or frail patient who will be managed conservatively independent of renal mass biopsy finding. And these two recommendations are based on expert opinion. For patients with a solid renal mass who elect biopsy, they recommend having multiple core biopsies over fine needle aspiration. And this is grade C evidence level. The therapeutic approaches are basically partial nephrectomy for a T1A renal mass, radical nephrectomy when worse oncologic potential is suggested by either tumor size, renal mass biopsy, or imaging characteristics, and then thermal ablation, whether microwave, cryo, or RF, is an alternative approach per the AUA for the management of T1A renal masses, which are less than 3 centimeters in size. And then they do recommend that a renal mass biopsy should be performed prior to any ablation. Now, active surveillance is usually recommended for solid renal masses that are small, usually less than 2 centimeters, or when the anticipated risk of intervention is or death outweigh the potential oncologic benefits of active treatment. When active surveillance is decided after discussion with the patient, of course, imaging should be done in 3 to 6 months to assess for interval growth, definitely with cross-sectional renal mass protocol, CT or MRI. And then there is a recommendation of renal mass biopsy or consideration for additional risk stratification if needed. So these are mostly the AUA guidelines. So lastly, I'm going to discuss our stand and our understanding of the use of percutaneous image-guided renal mass biopsy, mostly from the radiology and interventional radiology literature. So we're going to start by the question, why? Why do we need image-guided renal mass biopsy especially seeing the AUA guidelines, that there are very small, subtypes of patients or limited situations where they think that mass biopsy is needed. So why? Well, because approximately 15% of dissected renal tumors are benign. The incident ranges really from 7 to 33%. This is based on a meta-analysis done on approximately 27,000 patients from 2013. And another study where they examined 815 nephrectomy specimen for renal masses measuring less than 7 centimeter. 16% of those resected tumors were benign. And of the benign tumors, the most common tumor is Oncocytoma, accounting for 70%. And then the next most common is Angiomyolipoma, accounting for 14%. And then other less frequent pathologies were cyst, leiomyoma, cystic nephromas, and abscesses. And then we all know that the inadvertent treatment of benign renal neoplasm is a very important problem in renal mass management. Well, there is the inherent surgical risk for any operation and general anesthesia. There are the surgery-related costs. There is a study that was recently done reviewing the basically impact of partial nephrectomies of benign pathologic diagnosis from 2007 2014, and they found the total cost burden for partial nephrectomy was up to $90 million. And then we all are aware of the morbidity related to nephron loss and CKD, and it was found that up to 85% of patients who undergo renal nephrectomy, radical nephrectomy, and 6% of partial nephrectomies develop a GFR less than 30 during up to 5 years. So what do we suggest? Renal mass biopsy should be used whenever there is imaging supportive of the use of renal mass because of either benign pathology suggested or aggressive renal malignancy. So the basically suggestions is whenever there is a small and the number that people agree on is less than 4 centimeter based on wide literature. Whenever there's a small renal mass, it is suggested to proceed with renal mass biopsy before. Small homogeneous hyperdense avidly enhancing masses suggest fat-food AML, so that's another recommendation. Whenever there's a T2 hypointense, also avidly enhancing mass on MRI, which suggests fat-food AML. Whenever there's a rapidly developing or ill-defined mass in patients with risk of UTI, this suggests pyelonephritis. Whenever there's an infiltrative renal mass, because the differential diagnosis other than RCC, which definitely could be infiltrative, is urothelial carcinoma and lymphoma. And then whenever there's multifocal renal masses. Now, percutaneous image-guided renal biopsy can also, in the setting of known malignancy, it can subtype and grade RCC and then stratify less aggressive RCC for consideration of active surveillance. And then it is important to do whenever we have a solid renal mass with known extrarenal primary malignancy to differentiate metastasis from a second primary neoplasm. And then whenever there's unresectable solid renal mass, especially before systemic or radiation therapy, because they need histology, and these patients will not go to surgery. Now, the next question is, how do we do image-guided renal mass biopsy? So image guidance can be either with CT or ultrasound, and there's really no found difference in the sensitivity or negative predictive value for identifying malignancy in either modality. So it basically depends on how well you see it, and then the patient's factors, especially the body habitus, the operator experience, and then the availability. Ultrasound is definitely more widely available than CT. Now, it is recommended to do core biopsy over FNA, and then the coaxial technique is usually what we use. Needle size-wise, there are variable literature out there, but that what most people agree on is the use of an 18-gauge needle, which has a nice balance between less risk of bleeding and then a high yield of diagnosis. We usually do 2 to 3 passes. It definitely depends on the size of the mass. And then patient's positioning, they can be prone, ipsilateral side down can be considered to decrease respiratory motion, especially with small lesions, but definitely if the patient can. And then the supine positioning is usually done for transplant kidney. Renal mass biopsy can be done with conscious sedation or local anesthetic. It depends on the institution policy. And then the post-procedure monitoring usually is between 1.5 to 3 hours, again, depending on the institution. Core needle biopsy has a high diagnostic rate. It is reported that the diagnostic rate is up to 90%, and the major complications are less than 0.1% and are actually even less than that in many other literature. The complications, if any, would be mostly hemorrhage, infection, pneumothorax, adjacent organ injury, and tumor seeding, although the risk of tumor seeding is extremely low and is reported to be less than 0.01%. And then the overall mortality rate reported is 0.031%, so pretty low. Now, a few words about FNA. It is done, but we should know that it does have higher rates of non-diagnostic samples. So the diagnostic material was adequate only in 68.4% of renal tumor compared to 100 in this study done in 2013 on 42 renal mass biopsies. There's also the caveat of the inability to perform immunohistochemistry due to the small specimen size, and then the potential need for on-site cytopathology, which creates a lot of workflow issues. Well, despite everything that we went over, the utilization of renal mass biopsy remains overall low. It is estimated to be less than 15% prior to surgery. A US survey actually showed that 32% of urologists say that they would never perform a biopsy on a T1A renal mass. And then another international survey revealed that only 29% of clinicians routinely biopsy renal masses less than 4 centimeters. So the summary, basically renal mass protocol, CT and MRI are the primary modalities used to characterize indeterminate renal lesions, often showing the enhancement characteristics of solid renal neoplasms and then they differentiate them from benign cyst and cystic neoplasm. However, once the diagnosis of a solid neoplasm is made, the biologic behavior of such neoplasm is often unknown. And although renal cell carcinoma is one of the most common solid renal tumor, as we saw, up to 33% of renal neoplasm in nephrectomies are benign, meaning that many patients underwent unnecessary surgery and the associated morbidity related to the surgery, as well as cost and risk of developing chronic renal disease. Radiologists play an important role in guiding the management of solid renal neoplasm, especially when small. And although they might be benign and malignant, solid lesions cannot be distinguished by imaging, but knowing the high incidence of benign tumor, it is our role to give a differential and then maybe suggest an image-guided biopsy when appropriate. And by that, I think I am done and I'm happy to take any questions.
Thank you, Ghada. That was a nice tour of renal masses, and thank you for instilling the confidence that it is okay to do a biopsy. I think traditional teaching used to be we would worry so much about bleeding and seeding of the tumor tract, etc. But I think, as you said, more and more recent papers say that these are less in number compared to how many unnecessary nephrectomies that get done. Like in the US alone, apparently from 2000 to 2010, there was an 80% increase in the number of nephrectomies when 1/4 of them at least were benign lesions and surgery could have been avoided.
Definitely. I think there is kind of a misunderstanding, and then there's lack of maybe papers where both radiologists and urologists are on. So I feel each ward is kind of going into one direction, and we need just more collaboration and basically to work together to encourage urologists, and even many radiologists would be surprised of how many, how many institutions actually recommend and do renal mass biopsy with really very low complication rate and high diagnostic yield.
I think what the other thing that would help is to get pathology on board, because if we can tell those fat poor AMLs and oncocytomas, which are less than 4 centimeters, I think that would save so many.
Which remains a challenge, but again, with a lot of immunochemistry and advances in pathology, I am sure that we can get better with that as well.
Sure. There are a few questions. I'll start with the first one. So Dr. Gautam Reddy asked, if we find a hyperechoic lesion in the kidney on ultrasound, how likely is it to be malignant?
So if it's more than 1 centimeter, the recommendation is always to get a CT or MRI renal mass protocol. And then the idea is that RCCs are, especially when small, the vast majority of them are hyperechoic. So whenever you have a large lesion that is hyperechoic, more than 3 centimeters, it is more likely to be an AML. But whenever you see a small lesion and that's the first time you are seeing it, the recommendation is to actually recommend a CT or MRI renal mass protocol if it's more than 1 centimeter. Less than 1 centimeter is kind of a gray area, because the thought is that it is too small. It might be still too small to characterize if it doesn't have macroscopic fat.
I think that brings us to the next question is, they're then asking, do you recommend CT or MRI for stratification?
Yes, so that's a very important question. There's no data to either, favor one or the other, but there's definitely talk out there, and then, from everyone's personal experience, that whenever the mass is heterogeneous on non-enhanced CT, and that's also supported by the 2019 Bosniak classification suggestion, whenever a mass is heterogeneous, it is better to further evaluate it with MRI. But that's mostly for cystic lesions or for lesions that are more hypo attenuating or borderline house-filled unit. So you can really go either way. Whenever a mass is smaller, I would say whenever it's peripherally located, CT might be better. And then I say that because we all know the caveat of MRI with the subtraction images, where you get registration artifact at the edge. So if a mass is peripheral location and small, I would personally recommend a CT. If a mass is not peripheral and it is, bigger than 1.5 centimeters, I would recommend an MRI, especially if it's heterogeneous on non-contrast CT.
Next question is, sort of ties into what you said. If imaging diagnosis already suggests that there is a malignant lesion, can surgery be done without biopsy and thereby avoid tumor seeding?
Yes, so number one, it can be, and then biopsy in these instances is important to stratify the grade of the tumor and the risk. It is not widely used and it's not recommended yet, and there's no data to support it, but I think more and more we're going to see more use of pre-nephrectomy biopsy to stratify the risk. And if there's no plan to do nephrectomy, this is another reason to do it, to stratify the risk and see if patients can be on active surveillance. And then the third thing is, I say again and again, the risk of tumor seeding is extremely low. Many experienced radiologists would say they've never seen them. There's actually one article I found where they said that up to 2010, there have been only 7 reported cases of tumor seeding. So it's really extremely rare, especially when you use coaxial technique.
I think it's a little bit of the old school teaching, which is still stuck in our.
Yes.
So I think that kind of answers. Karen Craig had a question. Why is it that 1/3 of urologists do not want a percutaneous biopsy?
Yeah, so we were just talking about that before we went live, that again, it's very hard, and then it's it's very hard to change in medicine in general, despite all the available data. And then also it's a little bit tricky for someone to let go of what they take care of, meaning that radiologists know how to do nephrectomies, they don't know how to do biopsies. It's basically allocating a big part of the management to radiologists. So in my personal opinion, that's what I think is more political and more psychological, if you want to say, that it needs some more work to change this trend. I don't think, the data support, especially for small renal masses, to go for nephrectomy, although as I've showed many examples, unfortunately, patient did get nephrectomies even for small renal masses.
I know. At least with the cystic masses, I think they've done a great job with the new Bosniak classification, where they've laid out every trivial detail so you don't over-characterize things as a over and unnecessarily send it to surgery. I think for the solid ones, there's definitely room for multi-society collaboration between urology, pathology, radiology for sure.
Sure.
Next question is, would you still do image-guided biopsy if you have a renal mass that is seen on CT and invades the adjacent IVC?
So we do if there's no plan for surgery, because most oncologists, at least at our institution, would want a histology diagnosis before starting systematic therapy. So yes.
Right. I think that's the thinking now with so many targeted therapies and tumor biology being so well studied. That's the argument for still doing the biopsy. In a renal mass with necrosis, which is high, do you recommend biopsy?
Yes, because many benign tumor can show necrosis. I showed an example of Metanephric Adenoma, which is a completely benign tumor that can show necrosis. So, and RCC with necrosis definitely are going to be more common. But given the caveat that other benign tumors can show necrosis, I would still do a biopsy.
Have you ever attempted biopsying the solid component of a Bosniak 3?
Yes, it's tough, but yes, definitely. So it all depends how well you can see it, right? Most of the time, if the cystic component is really simple cystic, on the non-contrast portion, you can see it. And then CT, is a great, CT guidance is great for that. But the challenge is whenever you can't, see well the solid nodule, especially when it's small, or if we are attempting with the Bosniak 3, if we're attempting to biopsy a thick septation, you can, definitely imagine how hard it would be, but it is feasible, and I think it's definitely worth trying. In these cases, you can get FNA, especially if it's small, and you can get cytopathology on site to get you confirmation, but it is feasible. And then the other thing I would say is using contrast to guide the procedures with ultrasound, which is underused, but it's very useful. We've done it with livers and with kidneys, especially when the mass is necrotic or when it has a cystic component, where you can use 2 different doses of contrast. One is to actually, look at it, diagnose it, and then the second dose you can give it during the biopsy to increase your confidence that you're not going through necrotic or cystic tissue.
I know you mentioned contrast-enhanced ultrasound. There's another question in general about role of ultrasound in renal mass.
So it is done sometimes to follow up, but that's especially for cystic lesions. And then I would say that it is mostly done to guide biopsy, or it is basically the modality where the incidental renal masses are seen. We don't do routinely follow-up ultrasound for renal masses unless they are cystic, like the Bosniak 2Fs, which need to be followed up, for up to 5 years. In these instances, I would see ordering ultrasound, but most of the time, and even for the cystic lesions, I personally would recommend CT or MRI, because they're more sensitive to find any worsening new solid component or irregularity along the wall.
Yes. Another biopsy-related question, and I think you addressed this with the coaxial comment you made earlier, but somebody wants you to be more specific on the technique, and they again asked you if you use coaxial systems.
Of course. So image guidance, we went over it, ultrasound or CT guidance, and then the imaging technique. Basically, if you're using each modality, we usually start with giving lidocaine to the skin, and then all the way into the abdominal wall, and then the coaxial system we have basically consists of a 17 gauge coaxial introducer needle, and then this needle is usually advanced under image guidance, whether ultrasound or CT, all the way to be anchored inside the mass. So the recommendation is to traverse as little renal parenchyma as possible. But if a lesion, cannot is deep enough, even with central lesion, renal mass biopsy remains safe. And then the introducer needle, which is the 17 gauge needle, the bigger needle, is anchored at the edge of the renal mass. And then the coaxial system has an 18 gauge biopsy needle, which we use mostly the semi-automated needle, where you advance under image guidance, and then you pull the cutting tray, which can be anywhere from 1 to 2 centimeters, or up to 2.5, depending on the mass of the lesion and the type of the biopsy needle, and multiple samples are taken. So you take one sample, you remove it, and then you can take 2 to 3 or even more depending. And I'm glad to answer any more specific question if they have.
Saw a paper recently which said 18 is no good, you need to go to 16.
I know. I think it was even like the older, they used to use up to even 14 and 16. And it might be, especially with 14, that's when the bleeding rate was even higher. But we've had great experience with 18. We rarely have non-diagnostic. I can't even think of any time where we had non-diagnostic pathology using an 18 gauge needle.
Nice. And then I had a question about the T1A staging. So I know AUA now says it is worthwhile doing biopsy even for T1A. Have you, in your experience, done those, and has it helped you in active surveillance?
So it definitely for patients with risk factors, so patients who are contemplating active surveillance despite a T1A usually benefit from biopsy. And then the size-wise is never an issue. So less than 4 centimeters, it's still big enough for a biopsy. And I would say we've done renal masses. I showed an example of a metanephric adenoma that was 1.5 centimeters, and we got a diagnosis using core biopsy. FNA is also, definitely reasonable, and many institutions do FNA and core at the same time to increase the yield. But for small renal masses, I would say that, FNA is definitely reasonable, and we see it used often for patients who would like to go active surveillance.
And what kind of AS protocol do you follow?
What protocol?
Active surveillance protocol.
Oh, so it's usually 3 to 6 months, CT or MRI renal mass protocol. It depends from even within the same institution or every urologist, but that's their recommendation as well, 3 to 6 months.
Sure. And then one last question, we've spoken about diagnosis. So somebody asked, what are the minimally invasive or image-guided treatment options available for RCC?
Great. So we go for ablation, and then it's a great option, especially for T1A tumor. And I did maybe briefly go over it in my slides. So even the American Urologic Association say it is an alternative for nephrectomy, although many, especially interventional radiology data says that it's equally as good. And then especially in New England, in this area, many institutions go for ablation and ablation first. It's less risk, and then it is similar recurrence rate, which both are very, very small. With nephrectomy, the caveat with ablations are there, even if it recurred, there's always an option to repeat the ablation. So that's why many people are very comfortable doing ablations. And then as long as the patient knows that even if it recurred, because with ablation, the main caveat would be to cover the mass and to have a good ablation zone. But if this was not achieved, that definitely would put the patient at risk of recurrence. But even if this happened, they follow them up routinely. And whenever you see the tiniest small enhancing solid component recur, you can repeat ablation. So it's not an issue. And then for what type of ablations, at our institution, mostly do microwave ablation, but cryoablation and RF are also accepted methodologies.
Thank you. I think that's all the questions we have.
Okay.
Thank you for an informative session. I really learned a lot and enjoyed talking to you. I hope the participants liked it as well.
I hope that too. Thank you so much for joining in.
Yes, and thanks to Health for the World for organizing this.
Thank you.
Yes. Have a good day, everyone. See you.
Bye.
Bye.